So I guess we can get started. It's 4 o'clock. I'm sure there'll be some more participants that are already kind of coming in as we speak. I guess I'll start off. Just want to say to everyone, good afternoon. My name is Stephen Upton. I'm a proud employee of HANSAmed. For those of you who may not know who HANSAmed is, HANSAmed Limited is a Canadian-based specialty medical device and pharmaceutical company. We've been providing products and services to dental clinics across Canada for over 20 years. I'd like to start off by welcoming everyone today to HANSAMED's Table Talk webinar. We're thrilled and honored to have Chrissy Ford today, who will be discussing dental hygiene during COVID-19 and beyond. We do have a Q&A feature, so please feel free to use that throughout the presentation. Before I hand it over to Chrissy, I'd like to give you all a short introduction. Chrissy achieved her bachelor's degree in dental hygiene at University of Alberta in the early 2000s. Some years later, she became a part-time instructor at U of A in the dental hygiene program. She is currently working extremely hard at reopening her dental clinic in Stony Plains, Alberta. It's just a little west of Edmonton. And it just opened or just reopened this week. So we may hear a little bit about her experience later on with that. And then finally, Chrissy is a founder, or is the founder and CEO of Advanced Hygiene Solutions. They provide comprehensive practice coaching and continuing education specifically geared for the enhancement of dental hygiene and dental hygienists. So without further ado, it's my pleasure to welcome Chrissy.
Thank you, Stephen. And yeah, thank you for inviting me to join with you today. It's always a pleasure to be able to reach out to a good group of hygienists and possibly, clinicians or doctors as well. So I'm just going to share my screen with you so we can get going on this guy here. Okay, can you see that okay, Stephen?
Yep.
Yep, perfect. Just going to switch over my stuff here. Awesome. Okay, well, I would like to welcome everyone as well, and thank you so much for setting aside time. I know it's a busy time. I'm sure lots of people are prepping to get back to work as well. So thank you for spending an hour with us for some good information. I know that some of us have actually returned back to work, and for me, it was my first week back. Monday was my first official opening day at my clinic. We have a large clinic, as Stephen said, just outside of Edmonton, Alberta. And yeah, I'm actually pleased to say, and we can definitely share more information at the end, that it actually went quite well. I think, and even talking in other provinces that had opened prior to Alberta, I think the consensus for most people, just being nervous about the unknown and not really knowing what to expect and what is the PPE and the changes going to look like. I think everyone was actually pleasantly surprised that it actually went better than anticipated. So that's always a good thing. We didn't hit any major roadblocks, and we had a good response from our patients. Our schedule was actually really full. I know that was a major concern for some people. Are people going to want to come to their dental visit? And to be honest, we had the opposite problem. We're going to need more hygiene hours to fit in the backlog. And don't get me wrong, there's those few patients that just don't feel comfortable even leaving their homes yet. But for the most part, people are wanting and willing to come in, and they're excited to get back to their hygiene care, which is great for us, and for us to get back doing what we love to do, which is helping our patients. So, okay, So Stephen introduced me. I'm not going to spend too much time, telling you any more really about myself, other than I just want everyone to know, if you haven't met me before, or attended one of my webinars or lectures, that I'm very passionate about dental hygiene, and it is one of my missions and my goals to just keep working forward, reaching as many hygienists as I can to empower and share my knowledge in new research and adjunctive therapies and all that we can add to our patient care to make sure that we're getting the best patient outcomes that we can for them. I have a huge passion in educating. Obviously, we all love to educate for our patients, but I found after being an instructor at the U of A that I found my calling in, educating others and peers. And that's when I decided to open up my own company, specifically geared just to dental hygienists. And then that kind of morphed into a little bit more of helping the teams as well. So I do have a separate company, which is consulting, separate from my CE, and I have a partner with that, Louisa Zylstra. And so it's just awesome. I am very busy, as Stephen mentioned. I'm an office manager at that large clinic. We have 26 staff members. I have 6 hygienists that work a day, and I have a part-time side business for consulting and CE, but I wouldn't have it any other way. I love what I do, and I do what I love. Okay, so we are going to talk about a lot today. We're going to cover a lot of ground. Anyone that knows me knows that, I usually run out of time. I can talk and talk and talk. So I'm going to try to stay on topic. I usually could actually spend about an hour on each one of these topics, but what I wanted to accomplish with today's webinar is just touching on all of kind of the hot topics, all the considerations and topics and concerns that hygienists are maybe thinking about during this time and heading back to work or having just gotten back to work. And I wanted to just touch on each one of those so that when you are back to work, you're just going to feel a little bit more confident and in control of maybe some of these concerns going forward. So what are some of the things we're going to talk about? We are going to talk about the changes in the hygiene appointment. So what's going to look different for us? Obviously, there's the very obvious, or PPE and things like that I'm not going to get into. But just going, what are the considerations that we want to be looking at in terms of patient care and diagnosis in different ways with just the changes with our COVID specifically. We're going to talk about COVID and its risk with systemic disease. So where does that put us, as being a clinician on that path for our patients and as a clinician, what role are we going to play in helping with that? We're going to talk about adjunctive therapies. Now, this isn't just specific to COVID. Obviously, I'm going to touch on why and where exactly is this, more important in today's world and what we're dealing with COVID-19. But I'm super passionate, and I've always, a lot of my lectures always come around to adjunctive therapies and making sure that we are utilizing all the tools that are possibly humanly possible to add to our hygiene toolbox so that we can achieve the best outcomes for our patients. And we're going to touch on aerosol management. This is a big one. Obviously, this is one of our major kind of, nervousness for hygienists to go back. When and if we can be utilizing our ultrasonics and our airflow debridement, how can we manage that ergonomically, and how can we be safe for us and our patients and feel confident, going back to work that we're safe. And then we'll touch on just what is the future of dental hygiene looking like? What are the differences that we're going to see going forward? Okay, so let's talk about the history of dental hygiene. So when we look at this picture, we think about, there was a time that we didn't use gloves, they didn't use masks, we didn't sterilize, hand pieces. In today's society, we can't even imagine that was a normal back then. So now going forward to today, obviously a little bit of an exaggeration, but for some people, this is how we're feeling in our operatory with our new PPE. I just wanted to just exaggerate a little bit in telling us that this wasn't the first major shift in dentistry. It's not going to be the last major shift in dentistry. And just to know that we have persevered through these changes before in the past, and we've made it out to the other side okay. And we will get to a new point, that we just can't even think back to maybe some of these PPE changes that we can imagine, like how did we used to practice without A, B, and C, right? So just knowing that, throughout history, we've been here, we've done it before. We're going to be okay. So let's talk about some of the changes that we're going to be facing going forward. Some of us are already starting to experience these changes being back to work. I know that some of us or almost all of us are going to be in the same boat, depending where, if you're in the States, what state you're in or what province you're in. Everyone has slightly different mandates from the regulatory body in what they're going to be allowed to do and not do. But I think it's safe to say we're all going to be in the same boat, that we're going to either be eliminating or reducing or limiting our aerosol producing procedures. So that means our airflow debridement, our ultrasonic scalers. This does make me very sad, as I'm sure most hygienists, the thought of hand scaling is not appealing 24/7 for sure. For me though, it really makes me sad because I know, and this is what I teach and I'm passionate about, of the roles that these procedures play in proper biofilm disruption. And knowing that, you know, there is going to be a time during this COVID, and without being able to use aerosols in the hygiene appointment, that I think there is a clear understanding that we're going to not quite feel as good about our biofilm disruption and our hygiene appointment. And I want to share with you today, what are the adjunctive therapies then can we utilize, not just during COVID, but after, but especially just really taking into consideration these adjunctive therapies are going to be even more critical for our patients, knowing that we're not going to do as good of a job in the biofilm disruption process. So, all right, so I've chatted with a lot of hygienists over the last couple months just through all this, and, you know, as the guidelines came out, a lot of hygienists actually, you know, would even say to me, and I've heard them saying to others, you know, is it even worth it that we go back without aerosols? You know, should we even go back, or should we just wait? What, you know, why don't we just wait? And my answer to that is we absolutely should not be waiting for our patients. There's maybe a small percentage of our patients that are in total health, that have minimal calculus, that have no bleeding, no inflammation. Then we can consider, is the risk to the benefit ratio, you know, is it realistic? Maybe for that small percentage of patients, maybe it is worth waiting. You know, for us in our practice, and again, I'll talk more at the end, we decided to take all children out of our schedule currently, unless they had an actual concern at this time. So we moved them forward, we made room in the schedule for our more high risk and our pressing perio patients going forward for all of the backlog. But also knowing, you know, we're trying to minimize people coming in and out of the practice. We're trying to eliminate those shorter appointments. So all of that kind of played into the role of what do we do with those really healthy people and the people that we're not concerned with. But for that other percentage, which we're going to get into stats here in a minute, there's a large percentage of our patients that don't fall in that health category. And for those people, I want to say, we need to remember and remind ourselves that our patients need us much more than just for calculus and stain removal. They may not know it, but we do, or we should know as clinicians, that we, you know, are responsible for so much more than that. And I love this quote from the CDHA, in basically just reminding us that our patients need us for much more, not just now, and for some people even more than they did before during this time of COVID. So I want to read this. I am a dental hygienist. I educate and empower Canadians to embrace their oral health for better overall health and well-being. Now, let's go back to the beginning there. Do you hear in this quote at all that I'm a dental hygienist and I scale and remove stain? You know, I remove calculus and I remove stain. We don't see that. It's a bigger picture. So I think it's time. And I mean, again, prior to COVID, this is literally what my passion and my mission has been, to, you know, get everyone on board that we have such a bigger picture to look at. And now with COVID, it's even more important. I think that we need to be looking through our profession through a new lens. With all the recent research and media attention with the oral systemic link, even in the past few years, dentistry has the opportunity to be perceived as the first line of healthcare providers. And I think it's time that we step it up. So who is at risk during this time of COVID-19? Who are our patients that we are going to worry about, you know, having complications if they were to get COVID-19? Now, while disease can make anyone sick, some people are obviously more of a high risk, and these are the people that have, you know, are medically compromised. So we're going to look at this list in a minute, but I'm going to tell you something that's very surprising that I came across. And I think while many of us assume that the patients that are high risk are going to involve airway type things, so people with asthma and COPD, these actually don't even make the top 5 on the list according to Public Health Agency of Canada for people that are at risk for COVID. So I think we need to be thinking of our high risk patients, who's going to be coming into our practice, and how are we going to help them manage this risk factor. So our patients with hypertension, our patients with diabetes, high cholesterol, heart disease, and dementia. So to me, and everything that I teach and that I know, these are all the same category of people that are also at high risk of just periodontal disease and that oral systemic link, right? So when we look at that, it brings us back full circle to the concept of total health beyond the mouth. We need to understand and evaluate that inflammation is the key to almost every, or the root to every disease. So autoimmune diseases, cardiovascular disease, cancer, pulmonary disease, arthritis, and Alzheimer's disease. And I feel as dental hygienists, we must translate what's going on with this inflammation research and incorporate it into our practices so that we can provide the best possible care for our patients. We need to understand that chronic oral disease can not only wreak havoc on the oral cavity, but obviously play a huge role in their systemic health as well. So let's get into a stat that's a little bit closer to home. So talking about periodontal disease. Now, obviously this is for the States, but it's very close to Canada. They say that 47% of adults age 30 and older have some form of periodontal disease, and 70% of adults over the age of 65. So those stats are quite alarming, because what I find and what I see when I head out into practice when I'm consulting is that there's a huge disconnect to the amount of perio patients we are diagnosing and treating in our clinic to where these stats lead us. So if they're saying, you know, they're up to 70% of our adult patient base potentially could have some form of perio, then what are we doing to mitigate that? And are we diagnosing it properly? So this statement right here is going to bring us full circle in it, and I want you to, you know, write it down, take a picture of it so that you can understand the importance of what we do and how this relates to the systemic health and back to COVID. So inflammation of the periodontium is one of the most modifiable contributors to systemic inflammation. So when we talked about the root of almost all diseases is chronic inflammation, treating periodontal disease is one of the biggest modifiable contributors to actually helping with systemic inflammation. So that's huge. That tells us what we do every day with our patients is super important. And I think a lot of hygienists or clinicians don't give themselves credit enough. Again, if you're thinking to yourself, you know, should we even bring them in? Should we wait? This is why the answer is no, we cannot wait. These patients need us, and they need the equipment and our expertise in what we're going to be able to achieve with and for them. So if we look at these stats, 44% of all Canadian adults have at least one of these common chronic conditions. So there's 10 on there. And now if you look at the red arrows, these are going back to all of our high-risk COVID patients, patients that are going to have severe complications or die, you know, from COVID if they have these. So we're back to hypertension, diabetes, pulmonary disease, heart disease, and dementia. So these are the high-risk patients, and they're saying these are also 5 out of the 10 of these are very, very common with our patients that are coming into our practice. So we need to understand a large majority of our patients coming through our door have at least one of these. So we're back to that. Hypertension, diabetes, high cholesterol, heart disease, and dementia are our patients that we need to worry about. We need to make sure that if they're at high risk and they're over 65, are we treating them first thing in the morning? Are we making sure to really mitigate their risk when they come into our practice? You know, these patients are not patients that we should say, you know what, you're at risk, or maybe you should just stay home. I mean, you can't convince someone if they just don't feel comfortable leaving their home, then that's that. I mean, no point in stressing them out. But if they're willing and able, then let's just be smart about where we're putting them. But in understanding what we're going to achieve for them is so important, and it goes way beyond the oral cavity. So it brings me to, I believe, and this was even before all this hit, I believe dental hygienists are oral systemic specialists. We have an old profession with a new identity, and I really feel like now is the time that we're going to have a clinical paradigm shift. It's critical that we are looking at our patients differently, and we're offering them different treatments to be able to not only treat what's going on in their oral cavity, but their systemic health. So we're going to be looking at microbes, our host response, and genetics. We're not just going to be looking at how deep are their pockets and how much calculus do they have. So we're going to remind ourselves of the pathogens and periodontitis. Now, this goes way back to, like, you know, first month of hygiene school, you know, the boring stuff, but we have to remind ourselves of these bacteria and these key pathogens that we know are so important in the progression of not only periodontitis, but systemic chronic inflammation. So periodontal disease is an inflammatory disease with a microbial etiology. The mouth, we need to remember, is the portal to the rest of the body. And we know that these periopathogens can enter into our bloodstream and play a critical role in systemic inflammation and disease. So it brings us back, I'm sure many people have seen, you know, I always recommend, like, have a poster like this in your operatory or in your office somewhere, just to start the conversation with your patients in understanding, because we may know it, but if we don't educate our patients on this connection, then we're not really going to get anywhere. We need to remind ourselves that the mouth is the portal to the rest of the body, and that the mouth is talking to the body and your body is talking to your mouth. So I'm going to give you some stats here. These are very important in understanding then if we know our patients that are at high risk, and if we see some stats in exactly treating periodontitis or treating the oral bacteria, those bad pathogens, by doing that, how we're actually going to help minimize or mitigate our risk of these high risk patients. So pulmonary diseases, periodontal therapy is comparable to a 30% drop in LDL cholesterol, so the bad kind of cholesterol. Treating periodontal disease can lower systolic and diastolic blood pressure by up to 13 and 10 points respectively. This is equivalent to some kinds of medications. So that's huge when we're looking at, in comparison to someone going to a doctor and being on medication, to, hey, if you have active perio and we treat you after your active perio and we get you in remission, we may have a chance to actually reduce some of these systemic diseases for you. P. gingivalis, T. for Cynthia, and AA. Again, when we went back to those periopathogens, these are all our keystone issues with initiating gum disease, but they also have been found in arterial walls, in blood clots associated with heart attacks and strokes, as well as some kinds of cancers. They're also associated with rheumatoid arthritis and aspiration pneumonia. So again, these are 3 bad bacteria that are quite common with people with periodontitis, and they are being found in all aspects of many diseases. Then we've got T. denticola and P. gingivalis, another keystone pathogen. TD is one of the oral spirochetes that are found in 93% of the brains of Alzheimer's patients. This has been really big in the news in about the last year. A lot of research has been found on that. Recent studies have been published using DNA evidence to prove that gingivitis makes people more likely to develop Alzheimer's and makes the disease progress faster than in patients that'll actually already have it. And we're going to head into cardiovascular diseases. Men and women with periodontal disease are almost twice as likely to suffer from coronary artery disease as those without. Bacteria associated with periodontal disease and caries are directly connected and found in the thrombus of people who suffered heart attacks. So a huge connection with heart disease and the oral bacteria. For anyone that is on this call that has not heard of Dr. Bale and Doneen, I encourage you with all my heart to please look into what they do in their work. They're from the States. They are 2 doctors that have founded a prevention clinic for heart attack and stroke. And they're all about prevention. This is why I love them. They're kind of the pioneers of their time. And they have, without a doubt, and in their book, if you pick up their book on Amazon, it's a really easy read, but it really reiterates the importance of what we do. And really, they employ us to start to communicate with the medical and the dental fields in the connection between the two and how we can be working together. They absolutely, without a doubt, say that high-risk periodontal pathogens contribute to the pathogenesis of atherosclerosis, and they actually give each bacteria and how it relates to each of the stages of heart disease and how they play a role. So very in-depth stuff and a lot of research behind it, and they really have done amazing work. So if you ever have a chance to listen to them or purchase their book and read it, I mean, who doesn't know someone that has had heart disease, whether it's a family member or whether it's just going to enable you to chat with your patients on an easier level about it. It's a really, really good read. So this brings us back to our clinical aspect. What bacteria are working against us? If we do not know the bacteria that are present, then we're not going to be able to fully, to our full capability, treat what's going on. And we're not going to be able to fully know, are we worried about these keystone pathogens in regard to systemic disease? So if we know those bad pathogens are there, we see active perio. I will say though, in a lot of the testing that I've done, there's a test once in a while that really shocks you, that you actually might have done for a totally different reason, that they actually didn't have perio disease progressing yet. And maybe we did the test, and we're going to get into what this test means. Maybe we were doing it because they kept getting decay. We were checking for strep mutans, and it actually comes back that they're off the charts for AA. So one of the worst virulent bacteria for progressing bone loss and perio disease. So what that tells us is, hey, you're not there yet, but if we leave this and we don't treat it, there's a very high likelihood you are going to have issues with perio. But again, what are your systemic risk factors? Do you have heart disease? If you do, we need to worry about you having that oral pathogen in your mouth, and what can we do to mitigate and to reduce that so that we can make sure that it's not contributing to chronic inflammation throughout the body. So how do we do that? We're going to test for it. So there's DNA bacterial testing. Now, it's actually been out for quite a while, but I'm still shocked at literally, I would probably say out of all the clinics that I've gone to, there was maybe one clinic that was doing bacterial testing. I'm not really sure why it's not becoming mainstream yet. It's easy to do. It's cost effective. It's not super expensive. There is only one company that I know of in Canada that you can do this. There are companies in the States that you can send tests to as well, but you're going to test the bacteria in the mouth. They're going to come back with a report. You're going to test the tongue. You're going to swab the lingual surface of all your quadrants. You're going to send that away. You're going to have 5 little paper points that you're going to put subgingivally into the sulcus for 10 to 15 seconds. You're going to put that in the holding solution. You're going to fill out a form about all your patient information. You're going to send it away. And in a couple weeks, you're going to come back with this. They're going to let you know, they're going to look at 4 of the high-risk periopathogens, 3 of the moderate risk, and then they're going to also look at strep mutans for caries. So if you're having issues with decay. So it's going to come back like this, and it's going to tell you if you're above that line, if you're in the red, then we're concerned. It's above the level, the normal level that your body can fight. And we're going to see we're going to have issues with chronic inflammation in the body if these stay, at a higher level than they should be. We're going to see perio disease progressing. We're going to see more decay if strep mutans and candida are off the chart. So when you get this back, now we have a couple options. So we know now they need to be treated. We know that those bacterial levels are past where they should be. Now we have a few choices. What are we going to do with this information? Well, Orovital specifically, and again, every company kind of has its own options, but Orovital has a patented antibiotic rinse. So you're getting 5,000 times of antibiotic to the mouth, as opposed to having a systemic antibiotic, which is better for obviously antibiotic resistance and things like that, stomach. You're going to be able to use it for gingivitis, periodontitis, periimplantitis, even just for halitosis, tonsillitis, and hypertrophy during ortho. These are all the kind of considerations that you can consider using the antibiotic rinse if you did a test and it came back that they were high.
Chrissy, just to interrupt for a second, we have a question here. Is there any complex bacteria that are more important to combat when treating periodontal disease?
Yes, so these 4, the 4 that you see in the high-risk periopathogens, if they have those, and especially AA, PG is a very known keystone pathogen to be very detrimental to your systemic health. But in terms of bone, degradation and bone loss and progression of perio, definitely all 4 of those high-risk periopathogens are your 4 that you want to worry about. So if they even have 1 in that high-risk category, then you need to worry. If they have none in that high risk, but they have a couple in the moderate, we're worried, but we're not quite as worried. So I would say, from my perspective, PG and AA are going to be your top 2 in terms of progressing perio. Yeah.
Okay, thanks. And good question.
Okay, so let's think about our hygiene toolbox. When our gold standard of scaling and root planing doesn't get us the results that we're looking for, and research is showing us that this can happen up to 20% of the time, then let's have a look at our hygiene toolbox. What do you have in there to be able to provide another service and adjunctive therapy to our scaling and root planing? If your answer to that is you have nothing in your toolbox, then I hope that after today's webinar, you're going to be encouraged and empowered to look at your options. What else can you bring into your clinic to offer your patients? Again, especially during this time, our reduction of biofilm disruption is really going to play a role. Those active pockets that were there before, you're not able to flush that bacteria as well as you were to the base of that pocket without your ultrasonic and your airflow debridement. We need to be looking and being very, very on a close watch of all periodontitis and deeper pockets and pockets that are progressing, and absolutely taking out some adjunctive tools from your hygiene toolbox. So one of the first ones is to implement or to bring in, if you don't already have, locally administered antibiotics. So we call them LAAs. And these are local agents that are introduced to augment the clinical periodontal response of conventional scaling and root planing. So if scaling and root planing is doing a good job, there's no inflammation, there's no progression, then we don't need to worry. We keep doing what we're doing. But if we have active inflammation and progression and bleeding, then we need to be looking beyond. We need to pull some things from our toolbox to add in conjunction. They are considered fast and easy and effective treatments for the reduction of periodontal pockets, bleeding, and active inflammation. They are biodegradable, bioadhesive, and they are great for non-surgical, and they're cost-effective adjuncts for your patients. So one advantage of using local antibiotics is it eliminates, again, the side effect that you have associated with systemic antibiotics. I know that there's still kind of some old school dentists out there that they love their antibiotics, you know, any perio that they see, let's get them on antibiotics. And again, with the times that we're in, we absolutely need to be looking at different solutions, something that's going to be specific and it's localized to the area. You know, in today's world, we're getting more and more antibiotic resistance, and it's creating a huge issue. So if we can treat this locally, why not, right? Arrestin is a prime example. It is localized. It's a controlled release. It's a delivery system that's placed directly into the pocket, into an active diseased area. It is pre-measured and it can be placed in several pockets, usually within a few minutes. It's aminocycline. They call them microspheres, so they almost look like tiny little, I mean, from afar it looks just like a yellow powder, but tiny little microspheres, little tiny circles that you're going to place subgingivally. Both antibacterial effects for up to 30 days, and the reduction of collagen degradation resulting from tissue destructive enzymes. It works by modulating the inflammatory response along with the suppression or elimination of pathogenic bacteria. So again, right now, our instruments are going to remove calculus. They're going to disrupt some of that biofilm, but in a deeper pocket, you're going to have a tough time removing all the bacteria that's necessary, and more than likely, until we can pick up all those instruments, you're going to see more progression of those perio pockets. We need to be pulling out these adjunctive therapies. So I'm going to just play a little video here that everyone can learn a little bit more information specifically on Arrestin.
Scaling and root planing, SRP, is a cornerstone of periodontal therapy. However, the microanatomy of the teeth provides many nooks and crannies where bacteria can evade even the most skilled dental professionals due to the limitations of their instruments. For example, the cemento-enamel junction contains tiny, scalloped recesses not visible to the naked eye. These microscopic recesses are smaller than the instruments we use, allowing bacteria to remain and grow. Dentinal tubules can also hide bacteria. These minute canals extend from the pulp to the dental enamel junction, and when bacteria enter, these canals can become fully colonized. Lastly, certain bacteria, such as the red complex species associated with advanced periodontal disease, can invade and live within individual gingival epithelial cells. These cells are also vulnerable to orange complex bacteria associated with gingivitis and gingival bleeding. When combined with scaling and root planing, Arrestin may play a vital role in treating periodontal disease by helping to reduce pocket depth and targeting bacteria where instruments can't reach, near the cemento-enamel junction, outside the dentinal tubules, and within the gingival epithelium. Arrestin, minocycline HCl microspheres 1 milligram, delivers a broad-spectrum antibiotic directly to the site of active infection. Arrestin starts as a fine powder, making it easy to deposit at the base of periodontal pockets. The microspheres immediately bioadhere, and the minocycline inside is gradually released and diffuses into the surrounding tissues, remaining active in the periodontal pocket for up to 14 days. Over time, the microspheres will completely bioresorb. 3 months after treatment, the addition of Arrestin to SRP has been shown to significantly reduce pocket depth compared to SRP alone. In the fight against periodontal disease, extend the reach of SRP by adding Arrestin.
All right, so a good informational video giving you a little bit more information on Arrestin. So a lot of people want to usually know, what is our case selection? What kind of patients or sites are we looking at? I mean, anything that is active that you're scaling and root planing isn't controlling or getting under control, we want to consider an adjunctive therapy. Obviously, we want to, all the considerations, we want to get their home care up. We want to look at a local antibiotic. So looking at isolated areas, this isn't a kind of treatment that you're going to say, you know what, you have bleeding everywhere, I'm going to put it in every single pocket. It's meant to be used in a deeper pocket that you're feeling, that you're, you know, is active, that you're having a trouble getting into, and, you know, cleaning to the base of the pocket, that kind of thing. So localized, following scaling and root planing, we always want to make sure that we've done our job in removing calculus and as much biofilm as we can, and then utilizing it with it. Immunocompromised patients or patients like diabetics that we know just their healing response is going to be affected. Periimplantitis is a great one. Again, we know with implants, it's not calculus related etiology, it's biofilm. And so if we're seeing issues with our implants, we want to be on top of that ASAP. And people like our smokers and our periodontitis patients. Okay, I'm going to touch on laser bacterial reduction. This is another adjunct that, you know, maybe you're trained on laser and you're utilizing laser in your clinic. I will say, again, I don't know other provinces, but there are some provinces that have kind of blanketed or put your aerosol producing procedures all together. So unfortunately for Alberta, they just say laser. They actually didn't break up the different procedures that you can do with laser, which made me sad because LBR, or laser bacterial reduction, is definitely not an aerosol producing procedure, but they blanket it under the term just laser. So unfortunately for now, we are without LBR in Alberta, but all of the kind of benefits that we can be utilizing would be great during this time for COVID for our patients. But they lower bacterial count in the aerosols, which is great for us and our patients. Reduces pathogenic bacteria from billions down to hundreds for up to 4 to 6 weeks. It can have delayed recolonization for up to 90 days in specific pockets and bacteria. It can help reduce bacteremia. So we know that there's a natural bacteremia just with scaling and root planing. You know, some of that bacteria is entering into the bloodstream. And if we do LBR prior to scaling and root planing, we can lower that bacteremia that's happening, and preventing cross-contamination from pocket to pocket is really helpful too. Okay, oral probiotics. This is something that, again, I'm quite shocked at that it hasn't become more mainstream. I think people are finally understanding what kind of gut probiotic you know, work is and the importance of it. And I think hopefully in the next little while, people are going to pick up and start learning more about oral probiotics as well. So a single mouth can be home to more than 6 billion bacteria, an impressive number considering there's 7.3 billion people in the world. So a lot of bacteria in that mouth. Now, some is good, some is bad, but we know that in a normal condition, bacteria live in balance. But when that balance is disrupted, then the disease process can happen and things can initiate. Things like stress, poor diet, poor oral care, obviously all those things can disrupt that bacterial balance. And these are all the exact things that most of our patients have undergone under COVID, right? So everyone's stressed about money and not working. People are eating poorly. You're at home and you feel like it's a weekend every day. So you're eating lots of snacks. That's what my husband and I have been doing. We need to get out of the snack truck. And so we need to now more than ever, we need, again, things that are easy and effective and cost efficient, you know, very cost efficient for our patients. Anything, you know, like a layered effect. It doesn't just mean you need to pick one adjunctive therapy. I look at it, whatever I can offer my patients that I know is going to be beneficial, that's not doing the exact same job. You know, oral probiotics is going to help eliminate and bring in good bacteria and eliminate bad bacteria, you know, from the whole entire mouth system. So, you know, the dorsum of the tongue and the cheeks and all of that. And then we're going to use our localized antibiotics for our really active deep perio pockets. Then we're going to get into host modulation therapy in a second here. But oral probiotics, they compete against the bad microbiota. Probiotics disrupt the formation of harmful plaque of biofilm by competing for binding sites, competing for nutrients and resources, and releasing antimicrobial compounds. These inhibit disease-causing microbiota. So that's basically in a nutshell what oral probiotics are doing. So BioGaia is an innovative Swedish healthcare company with 25 years experience in developing all products in probiotics. BioGaia Pro Dentist contains the patented lactic acid bacterium Lactobacillus reuteri. This is very well studied. I'm going to get into a couple of those in a second here. Each tablet contains at least 200 million live L. reuteri bacteria to help stabilize the bacterial balance. over the last 50 years, changes in our society like antibiotic use and stress and excessive hygiene. I mean, right now, all of those things are important. We have to have excessive hygiene, but unfortunately, it has a negative effect on our microbial balance as well. So L. reuteri is one of the species that has decreased just in general in our population. And the way that I look at it is, you know, when we're not getting enough in our diet. So again, just in today's society, we're lacking a lot of nutrients and vitamins and deficiencies, and we're taking a vitamin or a supplement to help with that. Same thing here. So a lot of us are having insufficient levels of L. reuteri, which is a common probiotic, or like a good bacteria that our body should have, and we don't have enough. A lot of us do. So we're at more of a risk now of the bad bacteria taking over. And these are all the things that we can look at using a probiotic to help with: gingivitis, periodontitis, decay, halitosis. And whenever I do a bacterial test and I end up using the antibiotic rinse, I always make sure that afterwards they are using a probiotic like BioGaia ProDentis. So BioGaia probiotic products with L. reuteri are among the most scientifically and well-documented probiotics in the world. To date, the efficacy and safety of BioGaia's different strains of L. reuteri have been documented in 217 clinical studies in 18,000 people of all ages. So it is very well researched, which is what I love about this company. Lactobacillus reuteri has been tested in 109 studies in children from newborns up to 18 years old, and 101 studies in adults. So safe for children, safe for adults, safe for everyone. How are we going to use it? It is a probiotic lozenge. It's mint flavored. You use it regularly for good oral health, for prevention, 1 to 2 times a day for prevention. And if there is concern, gingivitis or halitosis or perio, then definitely 2 lozenges a day. And you let that lozenge melt in your mouth, and preferably after you've cleaned your teeth. That's how we're going to use this here. So I do want to say, before I get into host response, HANSAmed is, I think, Stephen, you can answer me this, are you the only company that sells BioGaia ProDentis in Canada?
Yes.
Yeah. Okay. So I will let you know, I mean, prior that I started purchasing and selling this in my clinic, I did some research, and you can order a lot of oral probiotics online, but this one is the only one in Canada that you can resell in your dental offices for your patients. So definitely, if you want to know more information, there's a lot of great studies that you can, you know, ask HANSAmed to send you and get more information.
Yeah. And one thing I can add too is if the office is going to introduce it to their patients can also purchase this through Amazon if they prefer, so that they don't always have to go back to the clinic.
Okay. Is it the same price point? Like, would they get the same, or it's
so yeah, if you purchase it through the office on a bulk purchase can get a lower price, and then they can pass that price on to their patients themselves. The patient just prefers to purchase it themselves, then they'll have to pay the regular retail price.
Okay. Awesome. Okay, so we're going to get into our next topic on host response. So periodontitis is an inflammatory disease involving the destruction of both soft and hard tissue in the periodontal region. Although dysbiosis of the local microbial community initiates the local inflammation, it's the overactivation of host immune response that directly activates the destruction in perio process. So with host modulation therapy, and again, a lot of people don't even know really what this is or what your options are with it, but it is a critical point when we're dealing with perio, and we're looking when scaling and root planing is not doing what we want it to do. We need to think outside the box, and we need to look at all these modalities. We need to remember that many oral pathogens are resistant to at least one standard antibiotic. Host modulation therapy aims to modulate the destructive aspect of your host immune inflammatory response to the microbial biofilm by utilizing the anti-inflammatory drug or oral product. So with host modulation therapy, it's about looking at the big picture. We're trying to manage our risk factors. Of course, we're removing plaque and calculus, but the missing link that often clinicians are missing that they're not utilizing or offering, results for this is looking at that host modulation. So looking at how can we manage our own host response to what's going on. This is the body's own inflammatory response to the insult. When the inflammation is prolonged or excessive, then periodontal tissue destruction occurs rather than tissue repair. So our option for this is Periostat. Periostat is the first and only FDA-approved prescription medication which modulates host response by reducing the activity of tissue-destroying enzymes released in your gum tissue without affecting bacteria. Sub-antimicrobial dose doxycycline, it's a 20 milligram tablet, taken up to twice daily, slows the progression of periodontal disease by suppressing or down-regulating the overproduction of these destructive enzymes, which are collagenase. At only 20 milligrams, this low dose of doxycycline puts the body back into balance by reducing inflammation and allowing periodontal health to be restored when combined with active periodontal therapy. So in a nutshell, this is meaning it is not an antibiotic. It comes from an antibiotic family, but it's not a high enough dose to kill bacteria. It does nothing with the bacteria. It does not cause antibiotic resistance. All that it is doing is it is changing the way that your body is responding. It's suppressing the collagenase, the enzyme that breaks down periodontal tissue. It inhibits your host response, and it can stimulate fibroblast and collagen production. Again, lots of great products here. I'm not going to go into great detail. If you want to know more information on any of these, you can definitely send Stephen a message or myself, and I can steer you in the direction of each of these companies and how you can find out more information. But again, all of our high-risk patients are critical in thinking outside the box. You know, we want to be controlling the chronic inflammation as well as the perio disease. So our diabetics, our progressing periodontitis patients, smokers and perio, heart disease and perio, and rheumatoid arthritis and perio. Okay, disease control seems pretty elementary, but I think right now more than ever we need to realize that our patients need more attention with home care right now. Again, with the reduction of proper biofilm disruption in our hygiene appointment, we need to reiterate to them that the concept and what they're doing at home is even more important. So maybe you've been trying to get them into an electric toothbrush and a water pick for the last 2 years. Really hit home to them the importance of what they are going to do at home with their disease control might make the difference of them being active or being stable with their perio disease. So we need to just really spend time and reiterate that. I think, you know, we need to think about, as clinicians, are we considering bleeding as our first sign of disease? Far too often, many patients, and we hear it all the time, oh no, don't worry, my gums bleed all the time. But even as clinicians, I think we're minimizing or undermining exactly what that bleeding response means and catching the disease process in the early stage before it progresses into true destruction. I recommend sell all products that you want your patients utilizing, sell it in your clinic. Don't make a profit, you know, sell it at cost plus a couple bucks. But patients are forgetful and they're busy. And if you have easy access at your office, they're going to be probably 50 times more likely to get into the home care regime that you're hoping for. Again, I know we sometimes need to just hold their hand a little bit. You would hope that if you told them what they need, they'll go out and be motivated to purchase it. But since we've started selling everything and anything in our clinic that we hope our patients are going to get, we've had such a higher success rate of our patients actually using them. So I suggest that for you for sure. Okay, we're going to touch on our layered protection plan. So when we can get back to utilizing ultrasonics and airflow debridement, we want to feel safe. We want to be utilizing everything that we know in our power to be confident in what we're doing. So the dental team should not rely on just a single precautionary strategy. Everyone is really concentrating on the PPE, but we need to understand there's so many more layers to all of this. You know, our pre-screening is so critical. You know, what we're doing with the temperature and their pre-screening form, making sure that sick people aren't stepping into your dental clinic. Our PPE is super important, but I'm not going to get into that. There's a million webinars on PPE. Go ahead and, you know, find what you need on there. But I'm just going to get into the clinical aspects. So reducing the bacteria load, what are we going to do prior to utilizing aerosols? So COVID-19 has obviously brought this topic to the forefront of our minds. I mean, a lot of this might be stuff that we should have been maybe doing before, but now it's really hitting home that we need to make sure to be using these. Hygiene obviously is using devices, or will be when we can use aerosols, that are going to be the highest risk in producing aerosols in the entire dental clinic. So what are we going to do to mitigate our risk on that? Pre-rinsing. So this is something we should have been doing before. ADA did a study that actually less than 10% of clinics were utilizing a pre-rinse prior to COVID. And that number is actually quite shocking to me. I didn't realize how many clinicians didn't know or didn't find value in that. And now that there's something scary out there, it's really kickstarted people into understanding the importance of a pre-rinse, which is good from my perspective. We used to be recommending chlorhexidine. Obviously, most people have heard hydrogen peroxide, 1 to 2%, 30 to 60 seconds. We're going to have our patients rinse prior to that. And a lot of clinicians are reaching out and saying, you know, what are you using? What do you recommend? A lot of clinics are just hydrogen peroxide in water and diluting. I'm going to let you know, patients do not like the taste of that. They complain every time. There's a lot of great options that are good, and they're pre-done, so it saves you time, and patients really like the flavor of them. Peroxyl by Colgate is a really good one. It kind of has a foaming action. I've been using Peroxyl in my clinic for ulcers and mouth sores and things like that for my patients for years. And Perio Plus is another oral rinse. They have a whole line. I've been using them for over 10 years, but in the time that COVID started to about 3 weeks ago, they developed an entire new product to add to their lineup specifically for pre-rinsing for COVID. So they already had a pre-rinse that had chlorhexidine and essential oils, and now they've added hydrogen peroxide to that. So a lot of the time you're just getting your hydrogen peroxide, which is great for viruses, but you're missing that kind of antibacterial aspect now. So Perio Plus I love because it has everything combined. You're getting your hydrogen peroxide and your essential oils and a low dose chlorhexidine. Again, you can purchase that through any of your dental dealers, Oral Dent, but the name brand is Perio Plus. They have lots of different options, but the pre-rinse is what you're looking for. It comes in a big bottle, and you just put it in your operatory, and you can have it for your pre-rinse. Okay, HVE is obviously our number one. The practical point of view is that we are going to reduce the aerosols at the point of contact. So that's number one for us. If we do that and we do it well, we can be effective for 90 to 98% of our aerosols. So that's number one. We need to make sure that we're close enough. We want the HVE to be 6 to 15 millimeters away from our working site. We need to make sure not just that our HVE tip and our user is effective, but how are your lines? Have you had your maintenance done? Have you done a test now that you're adding many more operatories? Have you checked to make sure that your motor can actually, provide enough power to all of the operatories in your office? So definitely these are things that we want to check prior to going back to work. But if all of those things are in play, then we want to consider, what are the considerations for hygiene and why is it such a big deal to use HVE in hygiene? To be honest, HVE was always recommended in hygiene before, and not very many clinicians did it. And I understand why. I get it. I'm a clinician myself. It was really not easy to use. It was hard ergonomically, hard to use as a single operator, just totally different round than what our dentists, we have four-handed dentistry, we have rubber dams, just many things in play to make the aerosol capture easier and better. So these are the things that we're going to have to look at to make sure that we can get our hygienists into HVE effectively, efficiently, and safely. We need it to be effective. We wanted to obviously capture the actual aerosols itself. We need it to be lightweight. Already ergonomics and thinking about all that hand scaling is just stressing all those hygienists out. Ergonomically friendly so that we don't have repetitive strain. Can a single operator use it? That's something that you want to think about. And can we move it? We want it to be 6 to 15 millimeters away. So if it's something that's stationary and you can't move it around the mouth, then it's not going to do the job that you need it to do. I just want to say before I move on, if you haven't been using HVE in your clinic and you're getting into HVE when you start using aerosols, be prepared to not like it. Just know that you're not the only person. It's not that you're doing it wrong and that you'll never get good at it. There will be a point that you'll look back and you'll think, oh, it was funny in the beginning that it was hard and I didn't like it. And now I'm to the point that I couldn't imagine not using it. So stick with it. It's like anything. There's a learning curve with it, and just know that you won't be the first one to feel those feelings. So I'm just going to quickly go through dry shield, like things like IsoVac and IsoDry. Please don't use this as your primary HVE in hygiene. It's great for retraction. It's great for pooling water and saliva, but it is not good for aerosol management on its own. If you have it and you have an extra oral device, then that maybe could be an okay consideration. But again, you can't move this guy around, so you can't make sure that it's close. The holes are too small to really capture the proper amount of aerosols that we're requiring. PureVac is a really great one. I know lots of people have seen this one. It's a really light hose, 69% lighter, 130% more flexible, so crosses off all the check marks and things that we want in ergonomics. It does have a mirror on it. Don't buy it for the mirror though. You will use the mirror sometimes, and sometimes you'll find it's not helpful. Buy it for the ergonomics and for how light it is, and knowing that it's one of the best options in terms of hygiene for HVE long term. It's quite quiet as well compared to normal HVE. Newbird is probably the second one that a lot of people are trying to, you know, compare. Should I buy the Newbird? Should I buy the PureVac? I loved the Newbird in terms of how it works in the mouth. It's great for retraction. The mirror is wonderful. It does have smaller holes, so the actual aerosol capture is less than what you're going to achieve with a wide bore HVE. If you were using it in conjunction, again, maybe with an extra oral evacuator, then maybe it could be a good consideration. Still a place for it, but if you're looking at just, hey, my number one concern is aerosol capture at the site, then going with a wide open bore is going to be a better option. So if you're like, hey, I don't want a system, I'm just going to use a regular HVE, you know, what kind of tips can I buy? So the Ventovac is just a half length standard HVE. It's shorter, so it's easier to maneuver. I find a lot of people, if they're using a standard like this, they just put a dry angle right into the cheek to keep from grabbing the cheek. The multi-axis, a lot of hygienists like this one. It's a little bit smaller of a diameter, so not quite as good of aerosol management, still good, but it is really good for not grabbing the tongue and the cheeks because of those little holes. The Trecovac it got a nice angle on it. It is a little bit longer, like it's a standard size, so it can seem maybe a little cumbersome, but it does have a flat edge on one side. Really, really good aerosol capture though with that one, and that one can be autoclavable, which is nice. So if you're going to go that route, you're absolutely going to need to consider some ergonomic factors. So there's some adjunctive tools that you can utilize. We've got the Aflex Assist Arm, and this has a couple different options. It has 2 attachments that attach to the back of your chair, one for your low volume, so that you have free hands for your high volume and your Cavitron, or one that actually, a new one that they just produced is for your high evacuation, and they have an attachment that you can utilize it for like a funnel for an extra oral evacuator. Then in the middle, they've got the Affinity hose. Now this is when I'm talking, we need to then, if you're going to use a standard HVE tip, what can you do to make it lighter and more ergonomically friendly? This is what I would suggest. Get into the Affinity hose, cut off all of your HV existing hose and switch over to this one. It's light, very similar to the PureVac hose. If you do go on the website, there is a $40 off coupon for either the HVE funnel connection or the arm, the low volume arm. And then the Cordys is an amazing product. It reduces strain. You're going to put either your Cavitron cord or your HVAC. There's a connection for your larger HVAC hose. And it's basically just it's lifting up the hose so that you don't have that drag and that strain for ergonomics. So again, getting into HVE is going to be tough. Everything that we can utilize, it's going to make ergonomic sense and allow us to use it long-term without repetitive strain is going to be important. Now here's the good news for Canada. I'm about to say something really big here. Everyone has been waiting because Cordys is only available in the States. And I just got the email this morning that they have just secured a distributor in Canada, and it is going to be through RDHU, which is actually a CE company that I work with as well. And they just figured out a deal, and they are going to be selling the Cordys in Canada. So they're going to offer the Cordys and the Pivot, which is the big one for your HVE. And right now it's not even up on their site yet, but you can contact RDHU. I think it's info@rdhu.ca for information on that. So we finally got it in Canada. I know we're nearing time. See what I told you, Stephen? I'm bad.
Hey, that's all. That's great. That's fine.
So I'm going to get into just what are some of the considerations right now that we can't use ultrasonic. So now is the time that we need to evaluate our hand instruments. So thinking about things like how well maintained are your instruments? Are they too thin? Are they actually sharp? Maybe do we need to look at additional instruments? So right now, more than ever, the quality of your hand instruments is going to be crucial for effective and efficient calculus removal. You know, we're going to be attempting calculus removal in areas and amounts that we aren't used to doing. We're used to using it in conjunction with an ultrasonic scaler and then finishing and fine tuning with our hand instrumentation. And now it's going to be strictly hand instrumentation. So go through your kits, make sure that your doctors are well aware that you're going to need time for sharpening. You know, if you're trying to attack heavier calculus with a dull instrument, you're going to have a tough time, and ergonomically, you will be in trouble. So just going to give you an example here. You know, a lot of people are like, okay, well, what do I want to consider then? What kind of instruments would I need for heavier calculus that I don't have my ultrasonic? Just anything in the rigid form is going to be really great. Rigid sickles, rigid universals, rigid Gracies, scalers that are specifically designed for heavier calculus. So I'm going to give you two really good instrument companies that they have good suggestions on how to manage your kind of heavier instrumentation at this time. PDT has a first line kit. They have this specifically in mind where they put together a whole list of rigid instruments for you, and it comes with a cassette. So you can reach out to them or check their website out on that. And then there's a lot of hygienists that are really worried about not having time to sharpen. So, you know, in this time of you know, trying to fit everyone in and not having time to sharpen, we need to have, you know, sharp instruments. Then maybe you want to look at a sharpen-free instruments. So LM from Bisco does have some sharpen-free instruments that you could definitely look into if you're looking for that option, and just know that you're not going to have time to sharpen. All right, so we're almost done here. So let's kind of talk about the future of dental hygiene. I think right now it's actually the perfect time to reevaluate our role as true healthcare providers and to add some new tools to our toolbox for our patients and their care. I think the patients will actually be more educated on their immune system and on viruses and bacteria, and it might actually play into our advantage, that little bit of silver lining of COVID, if you will. It's going to open up our discussion about the oral systemic link, I think, a little bit more easily for us and our patients, and I think we need to capture that and take advantage of that. I know a lot of times, you know, clinicians wanted and were trying to, you know, get their patients educated and to have them understand really how important their hygiene was. But I think now more than ever, it might actually be easier for us to get through to them. So I thought about when Steve and I were chatting, you know, what is hygiene going to look like? And I think it opens up a door. Now, I know there are some mobile units across Canada. It's really not a big modality, though. There's not a lot. But in kind of thinking, I mean, maybe this is opening up a whole new realm of mobile clinics and availability for those high-risk patients or senior patients that just don't feel comfortable leaving their home or their senior home, things like that. So I think we might see a shift. We might start to see, you know, more of these mobile type of clinics. I mean, this isn't going to be the last bad virus, I think, that we're going to see. So I think going forward, we need to figure out for the next time, what are the ways that we're going to be able to keep doing our hygiene care and our dental care if this happens again. So what can we put into place? So, I mean, obviously having a vaccine is going to be helpful. Having, you know, point of service testing so that we know, you know, is it safe, so that we can actually start peeling back and relaxing on some of our PPE recommendations would be wonderful. All right, so I'm going to just finish up with this, this quote: "We can't change the situation. The only thing we can change is how we choose to deal with it." So it is what it is. And, you know, I'm a firm believer, let's not whine about it. Let's try to see a silver lining. Don't get me wrong. All that PP is hot for my clinicians. And I feel bad every time I go back there and I see a little sweat coming down. You know, we put our clinic a few degrees down just to help them. But I think that months from now, we will realize that we've kind of made it over to that other side, into a new normal. And right now we need to just think, we need to support our patients in this time and think about all the ways that we can help them and what else can we add to our toolbox to be able to get them through this time and beyond, and just helping them have better oral care and systemic health. All right, so that is it for me. I'm gonna stop my share here, and then Stephen, you can actually, if you even want to throw at me some questions while I transfer this over here. Yeah,
sure. So first off, I mean, thanks so much, Chrissy. It was extremely like tons of action kind of packed in there.
Yeah.
Which was great. I think, you know, your knowledge, your experiences, and really your honesty about a lot of different products is great to hear and really relatable, I'm sure, for a lot of the participants. So we do have a couple questions that have come up. So I'll start with Andrea's. She's asking if you have any recommendations for dental stools for hygienists, like arms, no arms, saddle.
I like the saddle. All of my clinicians in my office have switched to saddle. A few of them switched, and then a few of them tried it, and they've all made the switch. So ergonomically, it makes you, you know, be in the position that you should be in. And the first few days, you feel like you were riding a bike or a horse. It's a little bit hard on the body till you get used to it, but it only lasts a day or two, and my clinicians love it. A few of them started with the yoga ball, the kind of one that had the wheels, and in comparison, switching to the saddle stool. We have the one that separates in the middle. Some of them are like one piece, but it's very adjustable. Yeah, it's really great for ergonomics.
Okay, thanks. Just so everyone knows as well, the webinar is going to be posted on demand. So since you've registered here, HANSAmed will also send out the link at a later time. So if anyone had issues, or they zoned in or zoned out, or whatever the case is, you'll be able to access all this information at a later date within the next week, okay? I guess one more question is, what iodine-based rinse are, again, in Canada, and how effective are they for subgingival irritation?
Subgingival irrigation or as a pre-rinse?
Oh, sorry, irrigation, yeah.
Irrigation. So, I mean, iodine has been around for a long, long time. I think it's kind of coming to the forefront a little bit again and again. They haven't done enough research specifically on COVID with it, but I came across a company called IoTech, and it's probably the kind of biggest one to watch that may become, you know, big, and you have to order it from online. It's not available through a dental supply company at this point. But they actually, what I love about their product, and I'm hopeful that it will become more mainstream and they'll do more even as a pre-rinse, there's a lot of benefits to an iodine rinse. And I think in terms of looking at it for multi-purpose would be great. They have a solution that's already, or that's actually concentrated. You can purchase it and your patient can put it in their water pick. So you're getting that really good flushing action at home too. So lots of great stuff coming from iodine. If that's your preference of choice for subgingival irrigation over chlorhexidine, I mean, yeah, there's benefits to both. You know, some people love iodine, some people love chlorhexidine. Really, for me, when you look at the research for subgingival irrigation, it actually can be, people have a perception of what they're doing, but then in reality, what you actually have to do to get full, you know, decontamination, it's very time consuming. You have to spend a lot of time in that pocket, where most people, they fill up a syringe, they do it, they have the suction, they're done. Really, in reality, that did nothing. So sometimes it's a perception of what they're doing. If you're just trying to give them a rinse after a heavy scaling and replaning, that kind of thing, then that's okay. But I think the studies were showing it's like 60 seconds you need to have that syringe, and so it's like multiple syringes of swishing and rinsing. Yeah.
Thank you very much. So next one I'll go with Patricia has asked a question. You know, when would you use Periostat versus Arestin? And would Periostat be more useful for those patients with more generalized inflammation, since Arestin's more localized?
Yeah, so I think you're trying to determine, is it a local site or is it a general issue? And then also risk factor. So if you know, and I'm going to just be honest at like a blanket, if your patient has periodontitis and they have diabetes, it's like a given. If it is not stable, they should be on Periostat. And again, you're looking at their host response and what it's doing to their body, as well as the prevention of further perio. Whereas Arestin, we're looking at treating a localized site. I mean, it might be a couple localized sites, but we're trying to treat a localized area as opposed to a generalized condition, as well as thinking their systemic connection as well.
Okay, perfect. Thanks for the question, Patricia. So I'll go with this. I'll go with a couple more here, if you're okay with time, Chrissy.
Yeah.
Okay. So we talked about a lot of different therapeutic products throughout the presentation. You know, what would be maybe your top 3 to have in your toolbox?
Well, I think there's multiple brands or things of different things, but if you're looking at, you definitely need a local antibiotic, right? So whether it's Arestin or if you have a different one that you're using, Periostat is a big one that I think there's not enough people that know about Periostat, and it's actually even in the last JADA guidelines, in that and scaling and root planing are the 2 things that are on their list in terms of treating perio disease that has enough research for their liking. And so it surprises me that not a lot of people are on board with that. Again, how I achieve optimal results is intermingling. Like I said, it's not just, oh, this person's going to be Arestin or this person's going to be Periostat. Quite often I do multiple modalities together. And those were the results where I was like, holy, get everyone in here and look at this result, right? Like amazing results, like periodontist, what a periodontist can achieve results. So these are like, you know, fall off on the floor results. And that's where I might have used laser, LAPT, so actually removing necrotic tissue, as well as periostat, as well as a local antibiotic. Or maybe I used a probiotic, or we did a bacterial test and they needed the rinse, and I used periostat, you know, just looking at multiple layers and the entire picture as opposed to just one thing at a time. Yeah.
Okay, cool. Thanks. So we have, you know, obviously a lot of participants here are from across the country. And as we know, there are tons of provincial differences in regulatory guidance.
Yeah.
I guess, you know, one question that has come up a couple times is, you know, why are provinces different?
With what they're allowing.
I'm not sure if you could answer that, but maybe in your experience, maybe you could touch on that.
Yeah. So it is a little bit frustrating for sure. And to talk on that, even there's disconnect even within a province from what the dental college or association recommends compared to hygiene. So
right.
It has been an issue, especially when you're looking within the same province. The problem is, like in Alberta, let's say, for us, we have a college and they're mandated to look at the public interest. We actually don't have an association, which is for their public members in Alberta. And I think we might be one of the only provinces that doesn't actually. I think someone is just working on or just finishing that. So that will be helpful. But then our dental college and association, they are both. They are mandated to look at the public interest, and they are mandated to also look at, you know, their members. So looking at the, you know, economical ramifications and looking at the whole picture together. So it can be difficult because sometimes people are looking at different things, but it all comes down to how are they analyzing the research? That, you know, that council, the people that are sitting in a room and looking at it, it's up to them to determine how they take the research that's in front of them. And most of them are seeing the same research. And it's just, how did they take it, right? Are they, and to be honest, even my own college has said personally to me, you know, we are risk adverse. That's our philosophy. We're going to go to the one extreme of safety, which is why, you know, we're not allowing this, this, and this. And I mean, we have to respect that's their decision. So it is frustrating. And I think as more research comes about, then obviously we'll hopefully start getting more and more on the same page. But I think it's about, number one, there's just not enough research yet. And depending who the council is, are they really risk adverse and they're taking it this way? Or are they open, you know, to looking at the literature and the research a little bit differently, and maybe they're a little bit more on the spectrum this way.
Right. So kind of like maybe building off that, and you went through the experience over the last probably month of, you know, reopening. So maybe to give, like, you know, some people across the country, maybe in Ontario, who they're starting to think about, or they are thinking about it, obviously. Maybe what's one thing that was a surprise for you that you weren't ready for when you were reopening? Is there anything that jumped out that that you wish you had more time to prepare or thought a bit more in advance that might help some people?
Yeah, I think the PPE is the big one.
Yeah.
For us in Alberta, in all honesty, we thought we had weeks until they were going to announce that we could go to routine care. And the government announced it on Friday, and we were to be open or could be open on the Monday. I was like, whoa. Like,
yeah.
So then I went into full mode of, it was my responsibility as the manager to get on the PPE and I knew that like N95s were going to be an issue, but I didn't honestly think like getting a gown was going to be such an issue. So we have like 4 different options and suppliers that I've ordered from, that it's like, well, if that one comes on Monday, then we'll be okay till Tuesday. And then when that one arrives, like it's being a juggling, yeah, a little bit of a mess. But that's probably the biggest stress. And what I can say is just make sure your office has been planning. I think it's really important for the team members to feel confident. And if you just plan to just say, hey guys, we're opening next Monday, everyone show up to work, and you maybe sent something on email on the plan, they're not going to feel confident, and then your patients are not going to feel confident about it. Even with a plan, we did like a dry run. We had all of our staff come in and we went through from like start to finish how our, you know, virtual waiting room would work. And then they came in and did their pre-screening and their temperature and who did what and whose responsibility. we went through all that, and Monday morning still felt stressful, right? We've all been out of clinic for 2 or more months, and then you throw in all these changes to add to that. I will say though, the difference between day 2 and day 1 was like night and day. Just getting that day 1 under your belt, you know, get through day 1, and actually you'll go home and you'll be tired mentally and physically, but you'll actually say, you know what, it actually wasn't as bad as I was expecting. And that's the word that all of my staff said, but even others that I know have all said it wasn't as bad as I was expecting.
Well, that's good news.
Yeah.
For sure. I think planning is important.
Yeah.
For sure.
For sure. Yeah.
So we have a couple more here. Is chlorhexidine or Peridex effective in lowering viral dose in mouth if used as pre-procular rinse?
No. So research has shown, which is why they're recommending to go the hydrogen peroxide. Chlorhexidine is for bacterial load. So great to kill bacteria, but does nothing, or there's not enough research to show that it's effective enough for viral load, which is why they've switched from recommending chlorhexidine as a pre-rinse into hydrogen peroxide or iodine.
Okay, thank you very much. And then maybe a couple more here, because we keep getting them in. I'm trying to keep up. Great, I love everyone's participation. It's awesome. What do you think about Cervitic Plus?
Haven't heard of that one.
Okay.
Is it a rinse?
It's Veronica who mentioned it. We can, I can keep this on the side and maybe we can look into it and respond to Veronica after.
Okay.
And really, I guess, maybe the last question, I know you touched on like PPE. Is there any specific PPE that you're using every day? Like which ones are like so important for you in your clinic to be operating in?
I mean, I think we all need to be open that there's different guidelines for different regulatory bodies in terms of masks. So I think the main concern first was N95s. When there was no N95s to be had, well then now what? So in Alberta, both our dental hygiene and our dentists, regulatory bodies have gone to say that level 3 and face shields are equivalent. So I think just making sure that your staff are feeling okay with that. And there's lots of, ways that you can make the mask fit better. You tie a knot in the side and you tuck it in. There's custom like plastic pieces that will go over your level 3 mask to make it fit tighter, things like that. So if you're hesitant or feeling nervous about using a level 3, there's definitely options to make it fit tighter and better. No, though, I mean, right now, and I don't think there's any province that's going to open hygiene with saying you can fully use aerosols. Know that, I mean, we're at a minimal risk, and I think it's good that we're slowly getting ourselves into it. Once we use aerosols, maybe the guidelines are going to change, and maybe they'll say, maybe we do need N95s, or I'm not sure where they're going to go with that. But definitely right now with hand scaling, my staff, I think, feel safe using a level 3 and a face shield. Everyone's pleasantly surprised that actually the face shields are you don't even feel them once they're on. I thought, that's going to be really annoying. It's going to be heavy. You're going to be like, oh, there's something on my face. But that's been a really easy switch. The gowns, if you're not over, like I know in Ontario, a lot of people are already using gowns. So I think that's great that you guys won't have that, something new if you're already doing that. But for Alberta, a lot of people weren't using a gown for every patient. So I think that, number one, just finding it and then utilizing it has been probably the biggest thing.
Yeah, and so you're using, I guess, a gown for every patient. Is it a reusable or a disposable? I mean, because there's so many other options out there. I mean, it's maybe what people get their hands on, but
yeah. Right now it's what you get your hands on. So right now we have disposable, but now there's no more disposables to be found. And now everyone's fighting over washable gowns. We actually have a service starting next week, and I needed to just figure out what can I do, what can I find that's going to get me through till my service starts, where it's a service that they drop off gowns and they pick it up weekly and they wash it and launder it for us.
Okay, so, nice.
Yeah. When you work out the cost, definitely look at that, because at first you think, oh, that'll add up over time. But when you think of the time that it takes your staff, how much electricity and water you're going to use, you're going to be doing laundry all day long with that amount of gowns if you have a large practice. This way was way more economical and easier by going with a service, for sure.
Okay, nice. That's really good feedback. So I guess maybe one more here. So it just disappeared, I think. Oh yeah, it was more around like appointments. Like, how are you setting up appointments? How are they spread out and stuff?
So again, depending where you are, you're going to have different regulations on the time that you have to wait in between appointments. And this is probably the biggest disconnect right now from province to province. In Alberta, we don't have any specific mandated time on the amount of time in between your appointments to let the aerosol settle. And so what that means is you have to check your HVAC system. It's all about your turnover of air. You're responsible to figure out where your turnover is. For us, we had our system upgraded so that we have a higher turnover. And for us, there is no wait time. Like, we don't have a mandated wait time. I have added personally for my hygiene team 20 to 30 minutes this first week to every appointment. And that kept them on time. Like sometimes they had a few extra minutes, but just getting everyone into the groove. And I didn't want people to feel stressed out. I'd say probably typically if we see 6 to 7 patients a day, now they're seeing 5. So in the large grand scheme of things, it's only really 1 less patient a day, but they have about 30 minutes extra per patient when you kind of look at it that way. And then next week, it'll go a little quicker. We probably will change it to about 20 minutes per appointment. And eventually we'll I don't think we'll ever, for a while get back to, exactly where we were, but I think maybe an extra 10 minutes at some point when we're flowing better and we've got the extra help. Like, really, reality for us, we opened and we're down a few dental assistants. So kind of having that extra help, I think that's where we're finding hygiene could go quicker. If you have like a float or a SteriTech or someone that's going to be utilizing and helping you switch over your rooms, that will keep your speed up and you'll be able to see more patients that way.
Great. Okay, well, I guess that's going to conclude our webinar for today. As mentioned, it's going to be available for all the participants, everyone who registered, again, online on demand. So we can go back and have a look at some slides that you may have missed, or you want to get, caught up on certain things. As Chrissy mentioned as well, feel free to please reach out to herself or me anytime really after, and we can address any more specific questions on products. I know there was some more interest in Arrestin, about billing Arrestin, and that's going to change province to province, and just as well as like some protocol and stuff like that. So I think feel free to please reach out to us, and we're happy to kind of assist you. Is there any closing notes or thoughts that you want to leave everyone with, Chrissy?
Sure. I did want to mention, just because we've talked a lot on ergonomics and the changes in what we're going to experience. My company is actually going to be having an ergonomics course, and it's on June 13th. So if anyone's interested in seeing some of my upcoming courses, Tiara Anderson is booked to do that, and she's fabulous. She's got lots of good yoga stuff behind her, and she's put together a great presentation. So that is going to be June 13th. You can find it on my website. And then we're going to have a few new ones coming up into the summer too, on myofunctional therapy and on sleep apnea for dental hygienists as well. So good stuff. But I just again want to say thank you for everyone that's still on, for joining us, and thank you to Stephen and HANSAmed for having me.
Yeah, it's our pleasure. Thank you so much, Chrissy. So everyone have a good evening.
See you, Stephen.
Cheers.